Well, we're going to get started then because I have to record the podcast at 9, as we have discussed here at TGH. I think like Shyla and Celia are on. Okay. So I know you all woke up on this chilly morning and thought, I can't wait to hear more about gram-positive bacteria. It's just a thrilling topic, I know. So we're going to sort of categorize our gram-positive cocci and rods, and then we'll have questions scattered throughout and sort of highlight some things that we don't usually talk about. So we'll start with gram-positive cocci. I'm sure you have all seen a similar flow chart or made one of these like in med school, like in your micro class, like gram-positive cocci and how you can categorize them. So you really divide it into staph and strep. And when we go to staph, which we'll talk about first, they use the coagulase test in the lab to differentiate Staph aureus from coag-negative staphs generally. Have you guys seen them do this in micro when you're doing micro lab?
Yes.
Yeah. When I did my micro rotation, I would see them do the slide test in particular, like something was growing there. Oh, could be staph. And then they like just do this quick slide test where they put it on there. And if it's coagulase positive, which is Staph aureus, it clumps. And so you get these little like clumpy looking things. The coagulase is also like a virulence factor, the fact that it does that. So it sort of correlates with why that's Staph aureus. Coag-negative staphs, obviously by name, are coagulase negative. But I just thought if you see that slide test, it's really quick in micro and they do it pretty often. Okay, so we're going to do our first question. Vince, could you read it for us?
A 76-year-old man with squamous cell carcinoma, the neck, undergoing radiation and chemotherapy, carboplatin paclitaxel, and CKD, presented with a desquamating rash on his right forearm and left cheek.
This is a picture of what it looks like.
Which toxin is the cause of the rash? Exfoliative toxins A and B, the toxic shock syndrome toxin 1, lipopolysaccharide, enterotoxin.
Any ideas from the group? I like your test taking skills. So what's your guess?
But you do get desquamation with TSST. Control A.
Yeah, and what do you call this syndrome? Yeah. Yeah, you can staph scalded skin syndrome, particularly if it's a systemic disease and he has multiple locations, so we're only shown one. Sometimes bullous impetigo is sort of a similar pathogenesis, but it's more of a local eruption. And then so what are the exfoliative toxins cause staph scalded skin syndrome. I think you mentioned what B is. What's that one cause? Toxic shock. And when do you see lipopolysaccharide? Yeah, that's like totally not staph at all, right? An enterotoxin. You can, when it comes to staph, it's a similar clinical syndrome. Toxin causes your Staph aureus food poisoning, so it's already formed toxin. And so Staph aureus, you guys have heard about Staph aureus forever. You guys know it's GPCs in clusters. It has a yellowish pigment, hence the name aureus for gold. And you guys, this is not a Staph aureus bacteremia talk. We're not going to talk about all the different manifestations, but I did want to highlight a few that we maybe talk about or see less commonly. These are all the things Staph aureus can do. You guys see many of these. So to highlight a little bit more on staph scalded skin syndrome, which came up in the first question, caused by Staph aureus, it mostly occurs in children, but it can also occur in older people who are immunocompromised in CKD, which was the setting of the patient in the question we have. And it has a desquamating rash that does not include mucosal surfaces. And often people do have positive blood cultures in this setting. And we already talked about the virulence factors. And this kind of came up in the question already, but just as a review of the different virulence factors for Staph aureus and how different factors can cause different clinical diseases. And then MRSA, this is sort of a random highlight of things we don't always talk about with Staph aureus, but for MRSA, the mechanism of resistance. Do you guys remember this? Do you guys learn this before? Everyone knows like MECA, the lab will tell you MECA detected, not detected, and what that means. Okay. And so it basically changes the penicillin binding protein. And so it's no longer able to, beta-lactams are no longer effective, is the point of that. And again, like I said, this is not a Staph aureus talk. So we're going to move along to our next category, the coagulase negative staph. So when they do that little coagulase slide test and it's not positive. So this is often when we get consulted, right? Have you guys gotten consulted for a coag negative staph in a culture? Yeah. And so is this the thought going through your head?
Probably.
Yeah, of course. And so we're not going to debate this to like, but when do you worry that if someone has an operative culture or blood culture with a coag negative staph, when do you start to worry that it's actually a real infection? Good. You evaluate the patient for signs of infection. That's very critical. I agree. Yeah. Yes. Yes. Because often we're consulted like on day 3 and you're like, why did you get these cultures? But okay. Yeah. And you guys sort of know this, but if there's multiple cultures growing the same coag negative staph, that's another thing. Often we see like positive 2 out of 2 blood cultures, but it turns out they're different coag negative staphs. Like that's not super concerning. In the appropriate clinical setting, as you mentioned. And then sometimes there are certain species of coagulase negative staph that have been associated with different infections. Yeah, and you mentioned which one?
Staph lug.
And what do you think when you see a staph lug?
That's more virulent and not usually a contaminant.
Yeah, exactly. Staph lugdunensis is second on the list here. It is a coagulase negative staph, but it acts more like a Staph aureus. So that's the one that if you see, you don't blow that off the way you do some of these other ones. Not that you guys would ever blow something off without a thorough evaluation. Staph epi was the most commonly isolated one that we see the most. Staph hemolyticus is notable. There have been reports of NICU outbreaks associated with this, and then it can have this heterogeneous resistance to glycopeptides. And then Staph saprophyticus has an association with UTIs in women of reproductive age. So that was sort of the overview of staph really quickly. And now moving on to our streps. And yeah, how do you guys classify streps in your mind? Hemolysis? Okay. Yeah. The big categories are hemolysis, your Lancefield groups, which can, Lancefield groups are sort of usually looking at the beta hemolytic strep and looking at the different cell wall antigens. Both of these systems are like 100 years old or some older. So they're very old systems. I think they get complicated, I think, for learning because things don't like nicely fall into groups all the time because again, these are sort of older systems and we've developed new or identified new species along the way. And when you say hemolysis, what are the different types? Yeah. And what do those look like on a plate? Like if you're looking at a plate, can you say if that's alpha or beta hemolysis and how so? You guys are way better than the group 2 years ago that just stared at me blankly when I asked them what it looks like on the plate. So this is a figure I liked because it sort of, they wrote an alpha shape and a beta shape and a gamma shape. So you can see what those actually look like. So as you guys said, the alpha hemolytic is a partial hemolysis. It can be a greenish color. Beta hemolytic is complete hemolysis. So it's clearing that blood agar. And then gamma hemolytic, it doesn't have any effect, as you guys said. Good job, guys. So we're going to go through each of these categories and talk about some of the bacteria in these groups. When you talk, we're going to start with alpha because alpha comes first. And so one of the big ones is strep pneumo. You guys have probably seen this. It's the leading cause of pneumonia and bacterial meningitis in young kids and older adults worldwide. We're going to look in the next slide at trends over time. We rarely worry about ear infections, sinus infections, pneumococcal pneumonia, and then invasive disease can be very severe when we see people with this. Not going to belabor treatment for some of these, but So I think this is just an interesting public health success over time. So we have different pneumococcal vaccines. The pneumococcal conjugate vaccines are generally more effective. And so PCV7 was our first one, and it was introduced in 2000. And so you can see, and the blue bars are all invasive pneumococcal disease, and then the gray bars look at a certain subtype, the 13. So you can see that when PCV7 was introduced, rates of invasive pneumococcal disease in young kids who were eligible for the vaccine dropped pretty substantially and pretty quickly. And then in 2010, PCV13 was introduced for kids, and rates dropped even further. And you can see that gray bar, the pneumococcal serotypes covered by the PCV13 dropped even further to like very rare cases. So that's really cool, and it makes sense, right? Vaccines work. I think what's even more interesting is that this graph is looking at adults age 65 and older. And so early on, it's sort of, the colors are annoying. Blue is all of it. Orange is the polysaccharide vaccine type, and gray is the PCV13 type. But if you look at that date where PCV7 was introduced for children, the drop in cases in children led to a drop in cases in elderly adults as well. So herd immunity, like decreasing the population burden of disease, it was effective. And so I thought that was really cool because it wasn't recommended for this population, but they still saw the benefits from limiting that disease in kids. And as you go over time, you can see that back here, like before these conjugate vaccines were available, most of the diseases, like most of this blue bar was accounted for by this gray bar, the PCV13 type. But as you get over here, many of the cases that would be of the serotypes that would be covered by PCV13, those are pretty rare. And so now there's a bigger gap with other serotypes filling in, causing the remaining cases. And that basically says what I just told you. Okay, John, you want to read the next question?
You're providing a holiday, you're enjoying a holiday feast with your family. Your Uncle Joe, a healthy 52-year-old man with no known medical problems, sees a commercial on TV about getting vaccinated to protect yourself and asks you if he should get a pneumococcal vaccine. He has never received the vaccine previously. What is the current recommendation for pneumococcal vaccination in Uncle Joe?
And presume he's truly healthy and not that he just hasn't seen a doctor, so doesn't know he has hypertension and diabetes. This 52-year-old man situation makes me nervous there.
Okay.
Good job reading your emails. So you guys should go with your colleague here. Yeah, this is a recent change. So as of October 23rd, 2024, pneumococcal vaccine recommendations have been updated to recommend pneumococcal vaccination for adults 50 and older. Even some of the CDC pages are not updated yet, so they have this like disclaimer above the top. And as a reminder of the different types, these are the 4 vaccines that are sort of used today, and then what serotypes they cover. And so all the PCVs are the conjugate vaccines, right? And the number tells you the number of different serotypes included. And then the PPSV is the polysaccharide vaccine, 23. So the 21 is very new. And you can see that it covers a lot of serotypes not covered by like PCV 20 or 15. That figure was interesting. And this is the current recommendations. So the first box is adults who have never gotten a conjugate vaccine. And so the CDC says they should get PCV 15, 20, or 21 if they're 50 and older, or 19 through 49 with medical certain risk conditions, which is our usual very long list, you know, like diabetes, hypertension, chronic alcohol disease, like everything you can think of pretty much. So while you can use 15, 20, or 21, if you use 15, you have to follow it with a dose of the polysaccharide 23 to try to get sufficient coverage. But then there's like all these other categories. And so I included some of them there because these pneumococcal vaccines, we've had different versions, different recommendations. So a lot of people you see will have gotten something in the past. So then there's always this question of like, what's the updated? The easy is if they've never had a vaccine and you can give them 20 or 21 and then they're vaccinated and then you don't have to worry about anything else, at least until they change the recommendations down the line. And this is like the MMWR, the CDC guidance on guidelines, clinical guidelines for implementing depending on different situations. It's like a pain, right? So they're kind enough to create this app and mobile tool called Pneumorex Vax Advisor. And so if I was playing with it and you just enter the person's age and if they have any of the corresponding conditions and which ones they've received before, and then it tells you what they're due for. It's really nice. Yes, it would also be good if you understand the guidelines, but sometimes it gets complicated with those. Like they got PPSV 23 like 8 years ago. What are they due for? The only thing is this Vax Advisor wasn't updated yet with that 50 plus guidance. So when I plugged in our Uncle Joe, it said he didn't need anything right now. But the current guideline is 50 and above should be vaccinated. Do you guys have questions about pneumococcal vaccines? I know this comes up in clinics sometimes too, because like if they got this and this, because a lot of our people with HIV have been getting vaccines over the years. And so it becomes an actual challenging question.
PCV 20 is one and done, right?
PCV 20 or 21 are one and done at this point. Yeah. So those are our preference if you have access and you can do it.
So much better.
So much better.
Yeah. And so as a reminder, we're in this alpha hemolytic strep category still. Who wants to read our next question?
42-year-old man is caught with sudden onset fever and collapse. He received an induction chemotherapy for AML 10 days earlier. He was taking Cipro, acyclovir, and voriconazole prophylaxis. Temperature is 38.5, heart rate 100, blood pressure 82 and 42. Wow. Respiratory 24, so septic. Widespread respiratory cackles, mucositis. ANC 0, cytopenic fever, diffuse bilateral infiltrates, blood cultures, GPCs turned positive in 11 hours. What is the most likely cause? Enterococcus faecium, Staph aureus, Staph hominis, strep pneumo, Viridans, strep. All over E.
And why do you guys say that?
The mucositis.
Mucositis.
Iris.
Zipper doesn't cover.
So neutropenic can break through on the fluoroquinolone prophylaxis and the mucositis as a hint. And can Viridans group strep make someone this sick in this clinical situation, right? Yep. You guys got the exact right situation. There's a big association between these Viridans group strep and strepmitis oralis with causing the septic picture in people who are neutropenic. So good job. And you guys know Viridans group strep. There's a lot of different groups. There are many more than shown here. These are just some of the common ones, just to sort of have a thought in your mind that they all do fall into different groups and they change over time. They rename things. It's all very complicated. Another group of strep that falls into this category are strep anginosus group. When you guys think of the strep anginosus group, what kind of clinical pictures do you think of? Abscess. Yeah, I always think of abscess as the key word. These bacteria love to form abscesses. So if someone's bacteremic, we're always, when someone's bacteremic, you think, where's it coming from? But for these in particular, you worry if there's a hidden or a quote abscess somewhere. It can be intra-abdominal, liver, other things. It can be head and neck or dental source. But you're always sort of have that in the back of your mind. And it's called the strep anginosus group, but it includes constellatus, intermedius, and anginosus. And they're a subgroup of Viridans group strep. And treatment, as always, is source control. And then sometimes because these form abscesses, depending on where that abscess is, you may think about broader coverage for polymicrobial infections, like presuming anaerobes there, if there's a big dental abscess or something. Okay. And then after alpha comes beta. So we'll move on to our beta hemolytic strep. Good. I have another question. Lauren.
Increasing left leg pain and swelling after a minor injury. A few days earlier, temperature is 38.5 degrees Celsius, heart rate is 118, BP is 110/75. Left leg with significant erythema and induration, white count of 18,000. He was started on broad spectrum antibiotics and taken to the OR, where findings were consistent with necrotizing fasciitis. Operative cultures grew strep pyogenes. Antibiotics were transitioned to IV penicillin G. Which antibiotic would be most appropriate to add penicillin? That you think, Glenda?
And why? Yeah. And what's something else you could use that's maybe not on this list of questions? Yeah. And so clindamycin is the right answer, clinda and penicillin for your severe group A strep infection. And then this article is sort of fun from CID. Should linezolid replace clinda as the adjunctive antimicrobial of choice? And they had 2 ID physicians sort of do the pro and con debate in CID. So it's sort of a fun paper to read. You know, you don't usually see that sort of literature. I think it's fun. I recommend it. And so group A strep can do a lot of different things. We see some of those invasive skin soft tissue infections, other severe infections. Strep pharyngitis is one we probably see less because often it doesn't make it in adults to the hospital needing an ID consult. And so some of the syndromes, what do you guys call this one?
Syphilis.
Erysipelothrix, good job. And the key there is that it's clearly demarcated. We see pictures of it on the leg. We also see it on the face. They can look pretty sick with fevers and chills. What's this one? More in kids. Impetigo. Yeah. The honey crust. And it doesn't have to be strep. It can be staph, but something to be aware of. Another one in this strep category or complication to be aware of is rheumatic fever. Our inflammatory response to group A strep. How many of you guys have seen rheumatic fever? Okay.
After the fact, like late.
Yeah. Yeah. Okay. I was just curious. I think a key question that comes up, I mean, sometimes you have to look up the criteria if it becomes a question for someone with this polyarthritis, this migratory arthritis, and maybe something else that makes you think of it. But a big thing is if someone has acute rheumatic fever, they're prone to additional episodes. And so they require secondary prophylaxis with antibiotics. And so sometimes that comes up. There's a whole lot of other strep species, just to not leave anything out of these clinically significant gram-positive bacteria lecture. So group B strep, we really, most commonly, it's an issue in pregnancy, or that's where you most commonly hear about it. You know, they screen pregnant women for group B strep and preemptively treat because it can cause severe disease in the neonate, or sometimes an elderly. What's strep galolyticus? What's that association? I know you guys can read it there, but yeah, we had one of these a couple months ago at TGH, a bacteremia. Yeah, they should. If they haven't had one, they definitely need one. Agree. Leuconostoc is in the strep family. We had a case of this causing either endocarditis or a joint infection. Yeah, it's intrinsically resistant to vancomycin, which is sort of fun. Fact to know about it. None of these are very common. Nutritionally variant strep, you know, the Abiotrophia, granulocytellate, the ones that can cause endocarditis. And I just look them up if those come up.
We're seeing a lot of that at the VA.
You are? Why? Do you always see a lot of it at the VA, or is that new?
All the cases that I've had with those are at the VA.
Dan just,
Dan was that, yeah. We've had more after that too.
That's weird.
Yeah.
I wonder why. Or did you change how you detect it? I don't, you know, like, is there some way that now we're... It just floats around the canteen. Okay. Continuing our whirlwind through the strep. So the gamma hemolytic, I actually didn't have a lot to say about this. It's really Enterococcus. You guys know about Enterococcus, right? We see them all the time. They're a normal part of the GI tract. It's really, we usually see them causing infections when people have been hospitalized. They've gotten a lot of antibiotics, and that whole balance of bacteria is off now, and Enterococcus can flourish. You guys know Ephesium is much harder to treat than Fecalis. Ephesium, it ends in M, tends to be mean. It's resistant, more likely. And then this is sort of a fun question that can come up. So which Enterococcus species are intrinsically resistant to vanc? You're going the right direction.
There's a
Same starting.
Yeah, it's a confusing name.
Gallium,
Yeah.
right?
Gallinero.
Gallinera.
Yeah.
It's like-
Yeah. You were getting there. You would recognize it if it popped up on a culture.
No, Galileo.
Anyone have more? And so this intrinsic resistance is driven by a chromosomal vaccine mechanism. But Cassila-flavus and Gallinarum, that can come up. It's in like the board review, like study guide materials and stuff, just a fact that they could try to trick people up on. For like our other Enterococcus species, they become resistant to vanc through Van A. That change the amino acid in the cell wall so they don't have affinity for vancomycin. So I like graphics. This one sort of shows how on top is vanc susceptible. That green vancomycin molecule can bind to the cell wall, prevent synthesis. But if you have the Van A gene in the bottom, then vanc no longer fits and it can't work. And so the bacteria continues to build its cell wall unobstructed. Fun facts. Okay, so that's all the gram-positive cocci. Nice review. Gram-positive rods, we focused on aerobic for this. I think the anaerobic bacteria are covered in a separate talk, and then the like filamentous gram-positive rods like actinocardia, those things are also covered in separate talks. But if you see a gram-positive rod, like your blood culture says positive gram-positive rod, what species do you think of?
Was not interested.
Bacillus non-anthracite, that is crucial.
Right.
Yeah, what else could it be? Okay, if someone's truly sick, Listeria. And then there's one more that I don't even know how to give you a clue for this unless they're like a fisherman.
Oh, Erysipelothrix.
There you go.
Rhusiopathiae.
Good job. So yeah, those are the 4 big categories. This is from ID board review. Like there's a micro primer. It sort of talks about how for gram-positive rods, the gram stain morphologies can give hints as to what the species is. And you can see here, like C. acnes is like clumping in that bottom corner. It takes a while to grow. It's slow growing, but it forms those clumps. Above that, the large boxcar shape, like Bacillus or Clostridium can be. Yeah, and then you can look at the rest. But I thought that was interesting. Corynebacterium, how worried do you get when you see that on a blood culture? No.
Depends what's going
You guys, try D fellows. Okay. Yeah, Corynebacterium are everywhere in the environment, so it's often a contaminant of cultures from different locations, whether it's blood or, sputum cultures can grow these. The one that obviously you would not call a contaminant would be diphtheria, which is it's the most clinically relevant Corynebacterium to know about for boards and things like that. We usually say we don't see a lot of it. It's unvaccinated communities. Hopefully it stays that way and we don't see a lot of it. But people can carry it asymptomatically, and that's how it gets transmitted. And you guys are probably all aware of the coating of the pseudomembrane coat that you can see on exam. Yeah. And then other coryneiform bacteria have also been associated with certain clinical syndromes, sort of like the coag-negative staph. Usually it's contaminant, but sometimes there are certain species that have these associations. So a breast abscess with this I don't know how to pronounce that, Kroppenstedtii, but we have had one at Tampa General where it grew from a breast culture, someone who had an abscess. These have been associated with nosocomial infections, so of course may still be contaminants. And Arcanobacterium can cause a similar pharyngitis to strep. Becky?
32-year-old woman presents with 1 day of fever, headaches, nausea, and watery diarrhea. Symptoms developed 12 hours after a picnic at which she ate a plate of sandwiches and salad. She was concerned she was 6 weeks pregnant. What is the most likely diagnosis?
Because the time frame, Listeria would be too short of
short.
the incubation.
Staph would be shorter.
Staph would be a lot shorter.
What could be?
Pate,
Fever, headache, and nausea, water diarrhea.
Clostridium more than like Bacillus would be more like the repeat.
It's the rice in the picture.
Pate sandwiches. Who eats that at a picnic?
Pate.
Yeah.
Pate is cool. See,
Yeah, I think so. I don't really eat pate, but yes.
with the meat.
Okay, what's your guys' guess?
It's pregnant as meat. Yeah. See.
It is. See, I don't think it's a perfect question. I pulled this from the Purple Book, not an official like board review. But I think they're trying to get at identifying some risk factors and then getting close to the time frame for Listeria. Like some of you guys were talking about the preformed toxin, Staph aureus would be a shorter incubation period. They say some of these other syndromes are more likely to cause vomiting than her syndrome, which is more diarrhea, but I think that's not always precise. And as you guys are well aware, have been many Listeria outbreaks lately. And so women who are pregnant are often counseled to avoid like deli meats that haven't been heated up because a lot of these outbreaks have occurred in ready-to-eat meat and poultry products. A big boar's head outbreak lately, this year as well, which could affect your pub sub if you're into those.
Liverwurst.
Yeah, liverwurst for all of your liverwurst.
I love it.
Yes. But, I think it's also important to note sometimes there's Listeria outbreaks associated with totally other foods too, like vegetables or other things, which I found very frustrating when I was pregnant. I was told not to eat deli meats, but then you'd hear about outbreaks with like ice cream or like vegetables. I'm like, well, what am I allowed to eat? So that's a personal problem. So that's Listeria. We've already sort of talked about a lot of this. It says Lauren was getting at the incubation period in the question said 12 hours. That's sort of on the earlier end of when you actually see the illness for Listeria. It's like 12 to 24-hour incubation for the GI illness. If someone develops a CNS infection, it can be a longer incubation period before signs of that are seen. And it's people who are pregnant are particularly susceptible to Listeria and also can cause pregnancy complications. So always on the lookout for this. Okay, so what's this? Yeah, don't read the caption that I forgot to blog out. Yeah, so we talked about Bacillus, not anthracis. This would be Bacillus anthracis, right? And so this is the eschar of anthrax, cutaneous anthrax, around with a lot of edema around it. It says that part is pretty pathognomonic. This hand shows like these hemorrhagic blisters that it can occur too when people develop anthrax. This is what it looks like these long things in culture. And then these spots that are more faint are the spores. In case anyone was curious there. So Bacillus species, there's two that are more clinically relevant. So anthrax is the first one. So cutaneous anthrax is the vast majority of cases. It starts with a papule, then vesicles form, and then an eschar. There have been associations in the past decade or so associated with heroin injection, though I haven't heard about them recently, to be honest. And then the one that's always worried about is inhalational anthrax, because this can be used for bioterrorism, right? And can be very high fatality rates. Bacillus cereus, the food poisoning, there's a diarrheal form that occurs in 8 to 16 hours after ingestion, so a little more longer, and it is heat labile. And then the emetic form, the vomiting form, this is what we always think of with the rice, is a preformed toxin that's heat stable. And so when people have leftover rice, they reheat and then develop vomiting shortly thereafter. We often think of this one. And there are many, many other Bacillus species. They're found in soil and water, but often contaminants. Do you want to read this?
Sure. A 63-year-old crab fisherman developed a painful lesion on his left ring finger. He first noticed throbbing at the tip of his finger, following which a slowly enlarging lesion developed. There was some stiffness in the index finger, but he had not noticed any swelling. He had not experienced any fevers or rigors. He felt as if the pain he was experiencing was disproportionately greater than the lesion seemed to warrant. On examination, his temperature was 36.8. There was a violet colored lesion on his left index finger of 4 centimeters in diameter. This had a raised border with central clearing. There was no swelling associated with the lesion, nor was there any tracking lymphangitis. What is the most likely causative organism?
And why are some of you saying B?
Correct.
Yeah. You guys got this. I'm going to show you a picture of someone with it. You can see it. It's a local infection. You have direct contact with an infected animal or animal product. So people who are in contact with animals, so your fishermen, butchers, farmers, things like that are the ones who tend to get this. That's what it can look like. It can be sort of ugly looking. And that's a random one that I've never seen in practice, but something to be aware of, especially for your boards too. So that's a quick review of gram-positive rods, and we sort of blew through this gram-positive lecture in 45 minutes.